In today's episode, we are going over a physical therapy guide to plyometrics, return to run, speed, and agility training. Let's get rolling. So, why are we talking about this? Well, first and foremost, especially for post op patients, I think physical therapists do a very good job in the early stages of rehabilitation. And we had a lot of education on how to deal with common orthopedic surgeries. So, we do a good job. On the flip side of things, we don't get a lot of education on the end stages of rehabilitation, particularly return to sport. So essentially, if you have a post op patient and you get a protocol from the surgeon, you usually have some pretty good guidance from that surgeon up until about 3 to 4 months. And then you get a lot less guidance. And it's up to the physical therapist to learn how to bridge that gap and get back to high level of a performance for that individual. And this goes for an athlete that's trying to get back to a field sport, but it also goes for the average Joe that maybe wants to get back to some sort of jogging program, or they just want to get back to being able to play pickup sports like, let's say, tennis or basketball or soccer or something along those lines, right? And generally speaking, a lot of the advancement of impact activities is not taught in most physical therapy curriculums, right? So we have a lot of questions end up being, when is it even appropriate to start plyometric training? How and when do we transition to some of the impact activity? Also, when we are allowed to start, what do we start with? And how do we progress over the course of time? What's kind of step one, step two, step three, step four, step five? If we are going too fast, how do we know? Right. And lastly, I think a big problem is that most information that we have out there is expert opinion. We don't have a lot of clear cut medical research that shows us when we're allowed to start stage one, stage two, stage three, so on and so forth. So, in today's episode, we're going to go over when is it okay to start with return to run activities, plyometric activities, right? We're going to talk about progressions. We're going to talk about very easy progressions and how to progress all the way to more advanced return to sport type activities. We'll also talk about how I like to specifically progress each part of impact. So basically, we're going to go with a return to run program first. And this is my foundation for all plyometric based activities. We're going to talk about how to return back to acceleration and sprinting. We're going to talk about how to progress through plyometric and jump training. We'll chat about change of direction and agility work. And lastly, we'll talk about conditioning. So once we've built all of these elements together, right? How do we get someone more conditioned so they can return back to sport or their activities over the course of time? Welcome to the Fitness Pain Free Show. This is where we help coaches and physical therapists like you get your patients out of pain and back to training. My name is Dan Pope. I'm a physical therapist, coach, personal trainer, and meathead. I have my dream job as a physical therapist, coach, business owner, and educator. I've been doing this for several decades now. I want to help you reach your goals, and that's the whole reason why I run fitnesspainfree.com. Now, first, I want to talk about some guidelines for non-operative patients because I feel like there's a big difference between how you treat a non-operative patient versus treating a post-op patient. So think about, let's say, a hamstring strain injury versus an ACL reconstruction. Obviously, two very different rehabilitations, right? So for non-operative patients, I think it's really important to meet the individual where they are in terms of tissue healing, activity level, so on and so forth, right? So a good example, let's say I have a hamstring strain injury. This person is halfway through their season. Let's say they're a competitive soccer player, about halfway through that season, come in, okay, strain my hamstring. Where do we start our rehabilitation? Well, we basically figure out where they are in terms of tolerance. We try a bunch of different things. We try jogging, we try accelerating, we try sprinting, we try change of direction stuff, right? And maybe we find that they're able to accelerate. So let's say they do fall runs 10 to 15 yards, and that's fine, doesn't really aggravate them. But as soon as we start to build up their top end speed and test that, it doesn't feel so good, right? So for that individual, I'm going to allow them to do change of direction drills, let's say some ladder work, let's say some acceleration stuff, but we're going to stay away from top end sprinting because that's really the main thing they don't tolerate, okay? How about a quad strain injury? Because different injuries are going to present a little bit differently. We still want to meet that person where they are. So let's flip this and let's say someone has a quad strain. For these folks, oftentimes they don't really tolerate acceleration very well, but maybe they tolerate top end sprinting. So if we do a build up run and work their way up to a higher speed run, they do quite well. But if we try to accelerate with them, they don't do so well, right? So for that individual, maybe it's okay to do more build-up runs, but we have to back off of acceleration temporarily and come up with a plan to progress back to acceleration in the course of time. How about an Achilles tendinopathy? So let's say you have an individual that's a distance runner and they come in and their Achilles is bugging them, but really they can tolerate speeds that are about an 8-minute mile pace or lower. Then really I'm going to allow them to run at any speed that's an 8-minute mile pace or slower. We might have to dial back on our speed work or hill work, but over the course of time, we can start to ramp up, right? Now, post-operative patients tend to be quite a bit different, right? So largely, these folks are usually out of commission for a period of time after their injury and before their surgery, okay? So they decondition at that point. And after the surgery, we have to protect the healing surgical site, and they actually become more and more deconditioned over the course of time. So usually we're starting at a much lower level in terms of strength and capacity. We also have to protect a healing surgical site. So they have to progress much more slowly. And we're starting from a lower level. Okay. And those are going to be the big differences between non operative and operative. And in today's lesson, we're going to focus on these operative patients, but these principles still do apply to the non operative patient. It's just that where you begin and how slowly you progress is going to depend a lot based on non operative versus operative. So, how might this vary based on the surgery? So think about an ACL reconstruction. Typically in these folks, they have a lot of weakness in the quads. And because of this, it may have a lot more trouble with deceleration, right? Or when you're jumping and landing into more and more knee flexion is more challenging. So for these folks, we have to protect the graft site. So we have to be careful with how aggressive we are with our quad exercises and how fast we introduce jumping and landing. But the other pieces, they're going to be weak in the quad over the course of time. They're going to have a hard time using that quad for landing as well as deceleration. So we probably have to be a little more slow with our progression, but we have to spend more time working the weaknesses over the course of time. Okay. How might this change for, let's say, a cam reduction and labor repair in the hip? So these folks may have more trouble with rotating and flexing at the hip. So think about change of direction activities. They may do okay with acceleration work. They may do okay with sprint work. When it comes to turning those hips, changing direction, doing ladder drills, doing shuttle drills, anything that requires a lot of change of direction, they have a little more trouble, okay? So early on in the rehab process, we have to be careful not to do too much flexion and rotation with our change of direction drills. But because of that, they're going to end up being pretty bad at it during the later stages of rehab. We have to focus on that once it's safe to do that, okay? How about with post-op Achilles repair patients? So one of the things a tendon does is it's going to store and release elastic energy, right? And early on, after you have a repair of this tendon, you're not pushing it too much with plyometric activity. But what's going to happen is that the tendon is not going to be very good at doing its job because we protected that for so long. So towards the end stage of rehab, when it's safe to introduce more plyometric activity, we have to have that tendon act like a spring. We have to do more work towards the end stage of rehab to get that function back, right? So obviously there's going to be a lot of nuance for each type of injury, or surgery, or the individual, right? However, I'm going to give you my favorite ways of progressing these, and then you can just tweak that based on the individual that's in front of you. So guys, if you like what you're learning about so far, then I want you to go and check out the Fitness Pain-Free Mini Course. So I made a mini course. It's absolutely free. That's the next logical step if you want to learn more from me. So in the course, we go over 5 lessons. That first lesson is how traditional schooling has failed us, right? So schooling is phenomenal from a physical therapy perspective, but doesn't really teach you how to work with high-level athletes in the fitness world, right? Doesn't always teach you how to do the lifts appropriately. Doesn't teach you about progressions and regressions of common lifts within the gym. Doesn't teach you how to program normally, how to write rehab programs, or how to write injury prevention programs for these folks. Next thing we go over, 7 reasons why people get hurt in the gym, 4 simple steps to getting your clients out of pain, how to build the career of your dreams and earn the respect of your community. It's all well and good if you know exactly how to work with folks within the gym. But if you can't get these folks through the door on a regular basis, then you're simply not going to be living the dream that you want to because you can't get the patients through the door that you want to work with. Okay, so I'll show you how to do that. And lastly, we'll talk a little bit about the Fitness Pain-Free certification, right? So I'll leave a link in the show notes. I definitely recommend checking this out. Once you sign up for the Fitness Pain-Free Mini Course, you will be automatically placed in the waitlist for the Fitness Pain-Free certification. Now, the Fitness Pain-Free certification is the course, the certification that I wish I had as a new grad. The that fills in all the gaps in knowledge that you don't get in physical therapy school. So, A, you'll gain complete confidence working with injuries in the strength and fitness world. You'll learn optimal technique for both health and performance from myself and some of the best coaches in the world. You'll master programming for rehabilitation and injury prevention. Have fun while earning a whole bunch of physical therapy and physical therapy assistant credits. You have 31.5 of those. You'll also gain NSCA credits as well as CrossFit credits if you need those. This is the equivalent of a university education in working with injuries in the weight room. I really believe that. I've been adding to this thing over the past 5 or 6 years. It's massive, a ton of phenomenal information. And lastly, the biggest goal is just to fill your day with the patients you love working with and building the respect and admiration of the communities you love working with. So I'll leave a link in the show notes. Sign up for the Fitness Pain-Free Mini Course. The certification is open 4 times per year for 1 week to enroll into. If you're on the wait list by signing up for the Fitness Pain-Free Mini Course, I'll alert you when that next enrollment period is open and you can get started. Let's get back to the show now. So before we actually get started throwing our patients into a whole bunch of plyometric training, we have to figure out when is it actually appropriate to begin impact activities, right? Here's a study by Davies et al. In 2015, which gives you some guidelines for when you can start running, jumping, changing direction. Just keep in mind, a lot of this is based on expert opinion, although it is probably good to have a few, at least, principles in place for when you can start doing these things. So first and foremost, I think it's important that you have surgeon clearance. You don't want to start a bunch of plyometric activity before the surgeon is happy with that. You're going to probably ruin your relationship, and you also risk hurting the person that's in front of you. Obviously, that's not good. This is going to vary widely based on the surgery, but usually this is somewhere between 3 and 4 months after the operation. We're looking for full range of motion. So let's think about post-op ACL reconstruction. We want to make sure we have full knee extension, full knee flexion range of motion. We should have minimal to no swelling. One of the reasons why I say minimal is because some surgeries, the Achilles comes to mind, that thing just stays swollen for years and stays thicker for a long period of time following the surgery. And if we waited for years to start plyometrics, it's just very unreasonable for the athlete that's in front of us, right? So more for knees, I'd say, let's make sure there's no swelling. But for some surgeries, there's going to be some swelling moving forward. So just take that with a grain of salt. Next piece is that we should have minimal to no pain during plyometric activities. One thing to keep in mind is if your knee hurts a lot when you're landing, it's probably going to change the way you jump and land. Okay. So our goal is to not have pain during these activities so we can have good technique, right? We're also looking for adequate strength. So this is going to vary based on the study that you're looking at, but probably somewhere between 70 and 80% or greater to start. We want to make sure we have adequate endurance. We also want to make sure we have adequate neuromuscular control, or basically decent technique. All right. I'm also going to read the guidelines directly from Davies et al. In 2015. So essentially, he doesn't want you to have any sort of pain in the lower extremity before starting a plyometric program, full range of motion to all joints, no swelling whatsoever. You should have adequate single-legged balance with the eyes open for 30 seconds, as well as adequate single-leg balance with the eyes closed for 30 seconds. We're looking for muscular strength within a 20% difference between side to side, so 80% plus strength. We're looking for only a 20% difference in terms of endurance, right? So let's say you do a single-legged squat test for 1 minute. You're able to do 50 repetitions on the non-operative side, and on the operative side, you're able to do 80% of those 50 repetitions. Your endurance would be symmetrical, at least enough to start, okay? We're looking for qualitatively good movement with patients with no compensation. So this is that neuromuscular control element. For example, if you have a post-op ACL and you're doing a single-legged jump on the surgical side, what you might notice is that they use more of a hip strategy to jump and land because they don't like to load up the knee, right? So this would be considered not good from a neuromuscular control standpoint. And what we probably need to do is to make that movement a little bit easier, or just wait a little bit longer, develop some more strength in activities like a single-legged squat or single-legged deadlift before progressing on to plyometrics, right? We should see no pain and good qualitative movement patterns with a single leg half squat. More about this a little bit later, but essentially, if you can't single-legged squat well, you probably can't land from a single-legged jump very well either. So it makes sense we have to build a foundation before we jump to more challenging single-legged movements. Davies et al. Recommended a squat of 60% of your body mass 5 times within 5 seconds with no pain and good qualitative movement patterns. They also recommend no pain and good movement patterns with lower level plyometric drills before advancing to higher level plyometric drills, right? So makes sense, pretty good guidelines there. Buckthorpe et al. In 2021 also had some pretty good ideas to help progress your athletes and figure out when it's appropriate to incorporate, let's say, low level drills versus higher level drills, right? And these guidelines were based off of ACL reconstruction. So take that with a grain of salt. Does that really apply well over to Achilles repair? Maybe. I think it's a decent guideline. But the other part is that these were designed for ACL patients, right? So they like to see a 1.25 times body weight single legged leg press before the introduction of running. Okay. So not only are we looking for near symmetry in terms of, let's say, quad strength before we return to these activities, but we're also looking for a baseline of strength compared to their body weight. Okay. They also want to see a 1.5 times body weight single legged leg press before going to unilateral plyometrics. So essentially, 1.25 times body weight single legged leg press is good enough for double leg plyometrics, but single legged plyometrics are more challenging to that knee. They want to make sure you have a larger baseline of strength. And before you actually return to sport, they like to see a 2 times body weight single legged leg press, right? So decent ideas on how to progress your patients over the course of time. They also like the limb symmetry index to determine when it's okay to start and progress certain activities. So limb symmetry index is a fancy way of saying what's your quad strength on one side versus the other, right? So if you have 70% strength, so let's say we strength test your quad on the non-surgical side, and it's 100 pounds of force is what you can produce. And on the operative side, you can produce 70 pounds of force. You'd have a 70% limb symmetry index. For Buckthorpe et al., they said this was a good guideline to start your running. So the introduction of running, you can begin when you have a 70% LSI. Once you get to an 80% LSI, it's okay to incorporate unilateral plyometrics. Once you get to a 90% LSI, you can start sports training, right? You're not necessarily performing at a high level, right? But you can start your sports training. And lastly, once your LSI is at a 1, right? So 100% strength left to right, you can return to high level competition, right? So again, these are just some basic guidelines, but I think it helps physical therapists out with their clinical reasoning so they can figure out how they can start to progress their athletes back to higher level activities. So another really important principle for physical therapists to understand is how do you know if you're going too fast, right? So if you start to progress someone faster than maybe they should be progressing, how do you know, right? So essentially, if you're noticing increased swelling over baseline, probably not a good thing. So let's say you introduce some plyometrics and then your patient the next day has a whole bunch of increased swelling within their knee and they have decreased range of motion as a result. We probably pushed a little too hard during that prior session, and we probably have to back off a little bit. The next piece is going to be pain. We already said that pain should be minimal to none. If we notice that knee starts to getting more and more sore over the course of time, probably progressing a little bit too fast, right? The other piece that is important is to make sure that people have good control during movement. So to go back to our earlier example on ACL reconstruction, these folks typically like to use a hip strategy when they jump, when they land. So they land with minimal knee bending and more hip bending, right? This is not what we're looking for. We want to make sure they can actually control motion through that knee. So if you give them a plyometric exercise that's too hard and the movement quality starts to look a lot different left to right, we're probably advancing a little bit too fast, right? Like I said, when folks are compensating, let's say with the ACL reconstruction, if they're landing stiff when they're running. So one of the things you'll notice in post-op ACL reconstruction, if you watch them jog for the first time, when they land on that surgical leg, it looks like they don't sink very much. So their head stays really tall and stiff when they land. And if you compare it to the opposite side, when they land, they have nice deceleration. The head kind of dips a little bit. And then when they go back to that surgical side again, it stays high and it stays stiff. Okay. So we want to make sure that people have good strategies when they're running, jumping, changing direction. You have to have a keen eye as a physical therapist to spot these. And if you're noticing that we have compensation, we want to make sure we regress the motion a little bit and work on building better movement patterns moving forward. And the next piece is soreness. So I'm talking about DOMS, not just necessarily knee pain like I was speaking about earlier. So in some folks, if you throw too much plyometric activity at them, they start to get a lot of muscular soreness. What may happen is that in future sessions, the movement quality might get a little bit worse just because their muscles are so sore, right? I don't see this being a problem if you're very slow and progressive with your introduction of plyometrics, but also keep in mind if your athletes are getting excessively sore within their muscles and they start to have poor movement quality, that's not good either. So, what are some important movements to focus on before introducing impact and plyometrics? Okay. So, some of my favorite lifts to try to progress before we do these activities are going to be barbell squats and trap bar deadlifts. I think one of the reasons why I like these so much is basically because they're going to mimic the same mechanics you'll see in a double legged jump and a double legged landing. Okay. So we can build up your body's ability to handle the forces of double leg jumps and landings just by squatting and deadlifting. So I like to have a good 4 to 8 weeks worth of loading in these movements before we start doing double legged jumping. The next movements I really love to work on prior to jumping, especially single legged jumps, are going to be single legged squats, skater squats, single legged deadlifts, and step ups. So, why do I like these? They basically are going to mimic the technique that you need during a single legged jump and a single legged landing, right? And I like to say that if your athlete can't perform a given movement slowly with their own body weight, there's no chance they're going to be able to do it with speed. So, essentially, if I can't single legged squat well, I'm not going to be able to single legged land well or single legged jump well. Okay. So, we're going to build up some proficiency in these movements before we move on to jumps. So, what are my return to run guidelines? Now, what I want to say is that for all of my athletes that want to get back to more impact, more sport that's going to involve cutting, agility, change of direction, jumping, and landing, I start them off with a return to run program. So, this is my base foundation of all of my plyometric training. Okay. Once we get through this return to run phase, then we start to progress to higher level activities like sprinting, accelerating, changing direction, so on and so forth, right? But this is the foundation of everything, okay? So let's say you have an individual that's starting off on their plyometric journey at month 3 or week 12. The first thing I typically throw at these athletes is going to be an assisted pogo jump. Now, if you're watching this on YouTube, you'll see it, right? So if you're watching the video podcast, you'll see this. If you're listening to this, I apologize. You won't see it. I'll try to describe it to you. But essentially, you take a nice thick band, you put it over a pull-up bar or a rig, you get some good tension in the band, pulling that band down towards your chest, and actually offloads your body a little bit, and you can perform pogo jump. So think about the motion of jumping rope, just bouncing up and down on the floor. It's a little bit unloaded because you're using a band, right? So you got to keep in mind, if you have an ACL reconstruction patient and you're starting these at month 3, they might not have left the earth for the past 4 or 5 months, right? So we have to start with easy stuff and progress to higher level stuff over the course of time. This is a really nice and easy starting place. So usually I start my athletes here. We're doing some form of assisted plyos for that first week. We do it about 3 times per week. I say somewhere between 2 to 4 sets of a variety of different pogo jumps, right? At week 13, so the following week, we progressed to an unassisted pogo jump. So we started with a band. Now we're taking that band away, getting a little more challenging. And then at week 14, so month 3.5, I will start a return to run program. Now, if you really want to, you can count the amount of impacts the lower limb is going to take during your return to run program, right? It takes a little bit of math. So let's say your typical athlete will run at a cadence of 160 steps per minute. During a 30-second jog, they're going to be taking around 80 steps. And if you're going to be doing a 10-minute total jog, a jog walk interval program, you can do the math to figure out exactly how many impacts they're taking. And then what you can do is when you're incorporating pogo jumps, you count the amount of pogo jumps, you progress them up over the course of time. So that when they start the return and run program, you know exactly how much stress that leg is going to take. You can just advance those impacts to the point where the return to run program isn't a big jump, right? If you think about acute to chronic workload ratio, we never want to have a huge jump in the amount of stress that the post-surgical site takes, right? So that's one of the things that's in my mind when I start to include pogo jumps. Let's get those impacts up to match the amount of impacts you take during your return to run program, right? So at the start of my return to run program, let's say this is at month 3.5, I usually start with walk, jog intervals. And the jog is not a sprint. It's important that you tell your patients this because I've had a few knuckleheads where we start a return to run program. And when I say to jog for 30 seconds and walk for 30 seconds, they think that means let's sprint for 30 seconds and then walk for 30 seconds. And that's completely wrong, right? We're looking for a nice, easy jog. We're starting to put a little stress through this area. We don't want to injure it, right? So usually I tell folks this should be a 3 to a 4 out of 10 on an RPE chart. Don't go nuts. This should be nice and easy for 30 seconds, followed by a casual walk. All right. So at week 14, I'm usually telling my patients I want them to do a 30-second jog, followed by a 30-second walk. In that first session, I want them doing 3 sessions per week. So think about a Monday, Wednesday, Friday. On that first session, they're doing a total of 15 minutes, right? So it's 15 cycles of 30 on, 30 off. Session 2, let's say that's Wednesday, 16 total minutes. On session 3, that's 17 total minutes. So you can see over the course of the week, I'm just gradually doing more and more. When we get to the following week, so week 15, now we are going to add 10 seconds onto the jog and subtract 10 seconds from the walk. So now I want my athletes doing a 40-second jog at a 3 to 4 out of 10 RPE and a 20-second walk. That first session in the week, 18 minutes. Session number 2, 19 minutes. Session number 3, 20 minutes. So you can see we're very gradually increasing the amount of jogging over the course of time. Once we get to week 16, we're just subtracting a little bit more time again on the walk and adding it to the jog. So week 16, we're prescribing a 50-second jog at a 3 to 4 out of 10 RPE and a 10-second walk. Session 1, 21 minutes. Session 2, 22 minutes. Session 3, 23 minutes. And then a week 17, now we're just straight jogging. All right. And that first session, 24 minutes. Second session, 25 minutes. Third session, 26 minutes. Now, if your patient is having trouble going straight from the 50 on, 10 off to straight jogging, then what you can try is maybe 3 to 5 minutes of a jog with 30 seconds of a walk and just looping that a few times just to help to bridge that gap. But I find that most folks do A-okay with this program, so we don't necessarily need to modify it. Once we get to week 18, I'm just increasing the amount of time slightly. So a 20-minute straight jog. Week 19 is going to be a 30-minute jog, so on and so forth. I typically try to get my athletes up to 30 minutes just because that's what most of the literature I've read has for return to run programs. But just keep in mind, this is going to depend highly on the athlete and their goals. If you have a soccer player, you might want to increase that a little bit more. If you have an endurance runner that likes to run, let's say, marathons, obviously you're going to have to build it up higher and higher. I think a good general principle is that you want to start to build volume first. And once they're starting to tolerate volume, so 30, 40, 50, 60 minutes, then we can start to increase intensity. So higher speed running, track work, all of that stuff. Okay. So volume first and then intensity. The next piece for me is that usually around week 18, I'm going to start doing acceleration and sprint drills. Okay. So largely the athlete has shown they can tolerate volume. We've ramped it up over the course of time. And once they've shown they can tolerate it well, we move on to higher speed movements. If you guys enjoyed this lesson and want to learn some more, I have another video for you. It is going to be an evidence-based guide to the treatment of patellofemoral pain. So if you're working with athletes that are having a little trouble running, this is a video for you. Check it out. If you guys want to check out the references, I do recommend reading through some of these articles. They were very helpful for me as a clinician. I'll leave a link to all of these in the show notes, and you can check them out. And lastly, thank you so much for your support. You truly allow me to do what I love for a living. If you're watching this on YouTube, please hit that like button, comment, and subscribe to the channel. It helps me out tremendously. If you are listening or watching the podcast version of this, please leave me a positive rating and review. Again, helps me out tremendously. If you want to go that extra step and support me further, consider subscribing to Fitness Pain-Free Insiders. It's a comprehensive educational resource and toolkit for the fitness and rehab professional. Think Netflix, but for trainers and physical therapists. You have premium content from me, very similar to what you're watching right now, but more in depth. You get updated monthly webinars delivered via me. You have over 100 webinars, ebooks, and complete guides at your disposal. You have access to a private Facebook group to have all your questions answered by me. You can decide upcoming podcast topics. And the best part is you can get started for just $1, right? And lastly, you can cancel anytime. If you do cancel, I'll be a little sad, but that's okay. I'll leave a link in the show notes, but if you want to get started right now, head to fitnesspainfree.com, click on the programs link, and then click on Fitness Pain Free Insiders Online Library to get started.